Congenital adrenal hyperplasia CAH is a group of autosomal recessive disorders affecting cortisol synthesis, with the most common form being 21-beta-hydroxylase deficiency. This deficiency leads to decreased cortisol and often aldosterone levels, causing increased ACTH levels, adrenal hyperplasia, and elevated levels of adrenal precursor steroids. Clinical manifestations and treatment vary based on the specific enzyme deficiency. Pathophysiology. 21-beta-hydroxylase deficiency leads to cortisol and often aldosterone deficiency, with compensatory ACTH increase causing adrenal hyperplasia and elevated androgens. 11-beta-hydroxylase and 17-hydroxylase deficiencies, less 11-beta-hydroxylase deficiency also leading to hypertension due to excess deoxycorticosterone, DOC, a mineralocorticoid precursor. Clinical features: 21-beta-hydroxylase deficiency, salt-wasting form, presents in the neonatal period with dehydration, vomiting, and potentially shock due to aldosterone deficiency. Simple virilizing form, presents with virilization and/or ambiguous genitalia in females and precocious puberty in both genders. 11-beta-hydroxylase deficiency, hypertension, virilization, and ambiguous genitalia in females due to excess DOC. 7-hydroxylase deficiency, hypertension, lack of sexual development, with female external genitalia in genetic males due to lack of sex steroid synthesis. Diagnostics: screening, neonatal screening with 17-hydroxyprogesterone levels, laboratory tests, elevated specific steroid precursors such as 17-hydroxyprogesterone in 21-beta-hydroxylase deficiency and DOC in 11-beta-hydroxylase deficiency. Hypocortisolism is common to all forms. Treatment: general, lifelong glucocorticoid replacement to suppress ACTH levels and reduce adrenal androgen production. 21-beta-hydroxylase deficiency, fludrocortisone for aldosterone replacement in salt-wasting forms. 11-beta-hydroxylase and 17-hydroxylase deficiencies, spironolactone to manage hypertension due to mineralocorticoid excess. Estrogen replacement may be needed for female development in 17-hydroxylase deficiency. Complications: acute adrenal crisis, especially in salt-wasting forms, presenting with vomiting, dehydration, and shock. Hyperpigmentation, due to elevated ACTH levels. Gender dysphoria in individuals with virilizing forms and ambiguous genitalia. Fertility issues due to hormonal imbalances and potential genital anomalies. Differential diagnoses: precocious pseudopuberty, primary adrenal insufficiency, PCOS, hyperprolactinemia, and Cushing's syndrome, among others, based on specific symptoms and hormonal profiles. High yield points: CAH is primarily due to 21-hydroxylase deficiency, presenting with cortisol and often aldosterone deficiency, leading to adrenal hyperplasia and excess adrenal androgens. Clinical presentation varies from salt-wasting crises to virilization and ambiguous genitalia, depending on the enzyme deficiency and resulting hormonal imbalances. Treatment involves glucocorticoid and, in some cases, mineralocorticoid replacement, with additional treatments tailored to specific enzyme deficiencies and symptoms. Clinical case: congenital adrenal hyperplasia, AH. Patient information: age, 3-day-old female newborn. Medical history: full-term delivery via normal vaginal birth, no complications during pregnancy noted. Presenting complaint: the pediatrician is alerted by the neonatal nursing staff about a newborn with ambiguous genitalia. The external genitalia appear virilized, with clitoromegaly and partially fused labial folds. History of present illness: the baby has been feeding well, but was noted to have unusual genital anatomy during the initial newborn examination. The parents are concerned and seeking explanations and management options. Physical examination: general. The baby is active, with no signs of acute distress. Vital signs within normal limits for a newborn. Genitourinary exam: ambiguous genitalia characterized by an enlarged clitoris resembling a small penis and partially fused labial folds resembling a scrotum, with no palpable gonads. Diagnostic workup: serum electrolytes indicate hyponatremia and hyperkalemia, suggesting possible salt wasting. 17-hydroxyprogesterone levels significantly elevated, suggestive of CAH. Karyotype: 46X confirming female genotype. Ultrasound reveals normal female internal reproductive organs, uterus and ovaries. Assessment: a 3-day-old 46XX female newborn presenting with virilized external genitalia, electrolyte imbalance consistent with salt wasting, and elevated 17-hydroxyprogesterone levels, leading to a diagnosis of 21-beta-hydroxylase deficiency, CAH, salt wasting type. Management plan. 1. Immediate medical management. Initiate glucocorticoid therapy, hydrocortisone, to treat cortisol deficiency and suppress adrenal androgen overproduction. Start fludrocortisone for mineralocorticoid replacement to manage salt wasting and correct electrolyte imbalances. Supportive care to stabilize electrolytes and hydration status. 2. Genetic counseling. Offer genetic counseling to the parents to discuss the nature of CAH, inheritance patterns, and implications for future pregnancies. 3. Surgical consultation. Refer to pediatric urology or pediatric surgery for evaluation and potential genitoplasty, with consideration for timing and extent of surgery, balancing the need for normal urinary function and potential for future gender identity considerations. 4. Long-term management. Regular follow-up with pediatric endocrinology for monitoring of growth, development, and adjustment of medication dosages. Education of the parents on stress dosing of glucocorticoids during illness or surgery. 5. Psychosocial support. Provide support to the family, connecting them with resources and support groups for families dealing with KH and ambiguous genitalia. Outcome: the newborn's electrolyte imbalances are corrected, and with the initiation of hormone replacement therapy, she remains stable. Decisions regarding surgical correction of the genitalia are deferred until the child is older, allowing for growth and further discussion about gender identity. The family is engaged with a multidisciplinary team for ongoing care and support. Discussion points: the importance of early recognition and treatment of CAH to prevent salt-wasting crises and stabilize the patient. The multidisciplinary approach required for managing CAH, involving endocrinology, surgery, genetics, and psychosocial support. The need for individualized care and long-term management, including the potential for gender dysphoria and the timing of surgical interventions.